Should be. Yeah. And I have to come pick this up when the question period starts. So I'll just come up and get it when you introduce me. And just about everybody's in. So.
Good afternoon. Could people please take their seats? We're about to start. My name is Sally Pipes, and I'm president of Pacific Research Institute. I would like to welcome you to our healthcare forum. The good news is that the forum is oversold. The bad news is that we have some people who are going to have to stand. If you are a person that has to stand, you're free to take a seat on the carpet if your legs get tired of standing. We are pleased to welcome C-SPAN to this forum. It's a first for Pacific Research. Should you want to know when the program will be aired, please call Pacific Research and we will give you the date. It'll probably be in about a week's time. Before introducing the subject and our speakers, I would like to give a vote of thanks to Sam Husbands, who suggested the format and the location for this event. For Sam, it must be, as Yogi Berra would say, deja vu all over again. He held similar forums like this about 20 years ago with Milton Friedman, and here we are today. There is no question that health care is, as Senator Henry Mallow recently said, the vogue issue of 1992. Recent estimates show that U.S. healthcare costs this year will be around $900 billion, some 13% of our gross domestic product. Yet we continually hear that there are 37 million Americans who have no coverage. Who are these people? Why are they uninsured? What is the answer to the dilemma? There are currently 34 proposals in the House of Representatives for solving the healthcare dilemma. They can really be divided into three separate areas: the Canadian nationalized healthcare system, the play or pay system, which the Mitchell Plan, and consumer choice. We are very fortunate today to have two internationally renowned economists to present their analyses of the healthcare situation. Dr. Milton Friedman needs no introduction. The 1976 Nobel laureate in economic science is a senior research fellow at the Hoover Institution. He has authored with his wife, Rose Friedman, who is also in the audience, many important and path-breaking books that have set the policy agenda around the world. Today, Dr. Friedman is going to discuss his solution to the healthcare crisis. His views recently appeared last fall in a widely read opinion editorial in the Wall Street Journal. Published copies of this article are available at the back of the room, so if you haven't picked one up, please do so at the end. Dr. Michael Walker is Executive Director of Canada's Fraser Institute. He is Canada's most quoted economist and is also a prolific author, editor, columnist, and media personality. In recent years, he has undertaken extensive research into Canada's healthcare system. When I was arranging this event, Professor Friedman's calendar, in connection with one of his many forthcoming events, the host of a particular event was a great man. He rightly corrected me and told me that there were very few great men in the world. There is no doubt in any of our minds that Professor Friedman is a great man, and that if Michael Walker is considered too young to be a great man, there is no question that he will be a great man in future years for his major contribution to changing the course of the policy agenda in Canada. Each speaker is going to speak for about 20 minutes, followed by audience questions, and we really encourage participation from people in the audience. Please welcome to San Francisco Dr. Michael Walker and Professor Milton Friedman. Professor Friedman will speak first.
Thank you, Sally. I appreciate your misrepresentation. I'm going to unilaterally revise Sally's program a trifle because I'm going to make this into a sandwich for you. I'm going to divide my 20 minutes into two halves. And the first half is going to precede Mike Walker, and the second half will follow. Because what I'll try to do in the first half is to show you a few figures and numbers about what kind of a problem we have in the United States, why we have it. Then I want you to hear Mike Walker tell you about one particular solution, the Canadian solution, and then I'm going to offer a very different solution, an American solution. And I think I'll be the bread and he'll be the meat. In the meantime, I'm delighted to be here with Mike. As Sally said, he has done an extraordinary job in Canada. He's been running the Fraser Institute there. He is young, but he's been running the Fraser Institute for 18 years and has made it into the most important single think tank in Canada. Has had tremendous influence. Their publications, particularly on how much Canadians pay in taxes and what their tax freedom day, how much they spend and so on, have become the kind of things people look forward to every year, like you look forward to buying your World Almanac. But Sally neglected to mention one of his most important achievements, which was that Sally worked with him for a good part of those 18 years. And we're delighted to have her, to have stolen her away from Fraser, have her here in San Francisco. But Mike deserves a little bit of the credit for the training and upbringing of Sally and how to run a think tank. In any event, to turn to my subject, nobody has any doubt that there is a real problem about medical care in the United States. But what is the problem? Sally mentioned people talking about 37 million people uninsured. But since when is it written in the books in gold that the only way in which people can get medical care is through being insured? That's one of our problems, that people take that for granted. But there is a real problem, and that real problem has arisen from the fact that we are spending more and more on medical care, and in some ways we're getting less and less. The article I wrote in Wall Street Journal was inspired by an article I had read some years back by an English doctor by the name of Gammon, who had examined input and output in the British medical care system, particularly hospitals, and had ended up with Gammon's law, that the more input in a bureaucratic system, the less output. That a bureaucratic system, he said, acts like a black hole that sucks in the resources. And that led me to wonder about the American system. And so I'm an amateur in health economics. I have not studied in detail. I cannot claim to be a specialist in it. But I just went to the usual ordinary sources and pulled down the data. And I want to show you some charts about what's happened in the United States to the amount we're spending and to what we're getting out of it. Let me show you, as it happens, it's much easier to do it for hospitals than it is for medical care in general, because in the case of both hospitals and medical care, input is easy. We have lots of very good figures on total expenditures, corrected for inflation, percentage of national income, all sorts of ways. The problem is output. How do you measure the output of the medical care industry? In hospitals, there's one very good measure of output, the number of patients taken care of each day, the number of patient days, number of hospital beds occupied. But when you come to the rest of medical care, it's not easy to define output. Output presumably wants to be health. The output should be making you healthier, able to be sick less frequently, et cetera, et cetera. Almost impossible to get a good measure. When I tried to do something, the least bad measure I could get was length of life. I'll come back to that. But for hospitals, it's very simple. And so I want to put a figure on for hospitals. Let's see if I can work this machine. I push the on, and then I push. Let's see. There we are. This is U.S. hospitals, 1946 to 1989. And what you see down at the bottom is the cost per patient day. How much it costs per patient in a hospital per day. That shows a dollar cost. But equally astounding to me is a personnel cost. If you calculate the number of persons employed in hospitals per patient day, in 1989, it was 7 times the number than it was in 1946. You ask, what are all those people doing? Well, most of them are filling out paper forms. Unfortunately, I tried very hard to see if I could get figures on the breakdown of hospital personnel between administrative and non-administrative personnel. I could get some figure. I couldn't get any decent figures that had any time span to them at all, and I finally had to give it up. The cost is 26 times as high. For every dollar that it cost you to be in the hospital for a day in 1949, it now costs $26 after adjustment for inflation. These are inflation-adjusted numbers. Now, those are almost unbelievable figures. Is anybody going to say that we've gotten 26 times as much out for our money? Very hard to believe that. Indeed, if you look at the record of output, the number of beds has gone down. The number of hospital beds is half what it was in 1945. Well, you can say we've made people so much more healthy that they don't have to be in the hospital so long. Well, that may be part of it. And that would be a very good thing. But that doesn't explain why the cost per patient day should have multiplied 26-fold. Now, the next chart I have is to show what's happened to spending. Oh, incidentally, to go back to that, can I reverse? Let's see if I can reverse. Yeah, wonderful. That vertical line there is Medicare, because as you will see, the really bad problems started arising after Medicare came in. It was a trigger that triggered the enormous expansion. And before Medicare, costs are going up, but they're rather gradual. And personnel is going up, but rather gradually. Now, if you look at expenditures, you'll see that before that's as a percentage of national income. And before about 1950, in fact, it's as far along as to, this is one of Mike's gadgets. Let's see if I can make it work. I probably got it backwards. What? Is the red dot shining? What? What do I do? There we are. You see how much she misrepresented the situation? If you look over here, you will see until about 1955, the total cost of medical care had been about 5% for decades, 5% of the national income. It is now 14%. And as you can see, that the fraction of that is governmental has gone up very sharply. And the fraction of the governmental that is federal as opposed to local has gone up also very sharply. I just want to run through these very quickly to see. Now, here's what's happened to private health spending. Health spending by you and me. And private spending, as you will see, was going up very, very gradually until about 1945, until the end of World War II. Then it started going up more rapidly. The linear trend is a trend figure fitted to the data from 1919 to 1939, to 1940, I guess. And that's where spending would have been if it had continued on that trend. But it started going up, too, very rapidly after Medicare. Now, here's what's happened to government spending. That's a picture that's worth 1,000 words. As you can see, before government spending had been going up until Medicare was introduced, but at a constant percentage rate. That's the logarithmic trend, showing a constant percentage rate of increase, fitted only to 1940. All of this is an extrapolation, and you can see we came back right onto the same trend until Medicare came in, and then the whole thing exploded. Now, if you put the two together, total spending, and this is the sum of what that linear trend was and what the logarithmic trend was, you will see that we would today be spending less than half as much on medical care. This is spending. These figures have all been dollars per capita corrected for inflation. So they've allowed for population growth and also for inflation. We would now be spending a good, as you can see, this is about $800, and this is about $2,000. So we'd be spending about 40% as much if trends had continued. That explosion is a very real problem that we're concerned with. And it shows what the problem is. The problem is that we are not getting our money's worth. The problem is that we're spending a great deal more than we ever have in the past, and there's no sign of a reduction in the rate of growth. And we're not getting our money's worth for it. Now, as I said, you might say, well, but you aren't taking into account the improvements in the quality of medicine and so on. The interesting thing is that with this explosion in government spending, the percentage being devoted to research has been going down, that the research spending was going up more rapidly before Medicare came in than it has been since then. And what's also interesting, as I said, the only thing I could find to judge the output, not of hospitals, but of medical care in general, was life expectancy. These charts show life expectancy at birth for black females and white females. I took females in order to try to get as homogeneous a group as possible so I wasn't mixing things up. And especially with males, wars come in and mess the thing up. As you can see, the fascinating thing is that trends which were fitted to 1910 to 1940 keep on being accurate all the way to 1960. And then, if anything, at birth they slow up. If you look at that, you would say, well, my God, we're getting less and less for our money. But that's very misleading if you look at the next chart, which shows what happens to the length of life, the number of years after age 65. At age 65. Now, I wish some of the physicians in the audience would tell me the answer to this puzzle. That was going up slowly until about 1939, and then it suddenly took off for both males and females. What was it that happened around 1939? Was it the discovery of penicillin and the antibiotics? That's about the only thing I've been able to think about. At any rate, you do not see that Medicare and Medicaid have had any effect on that at all. And so, as I say, I have concluded that what we have to say is we're spending a great deal more. We're getting less for our money in hospitals. Output has gone down. So far as general medical care is concerned, there's little evidence that there's been an increase, that there has been a substantial improvement. Certainly nothing proportional to the increase in the amount of money coming in. Now, Mike will tell you about how much better they handle these things in Canada and how they have the perfect recipe for you. Have I summarized your talk, Ray?
Just about. Give it away. Well, Milton, thank you very much for that introduction to my comments. And Sally, I want to thank you for the wonderful and complimentary comments that you made. I thought they were a little bit on the generous side when Milton wrote them, particularly his comments about the great man, but you carried them off very well indeed. And I'm grateful for that. I'm also grateful to have the great opportunity to come here to San Francisco and share the podium with a man who I greatly admire and who has been a great source of inspiration to us all, let's face it, on a whole range of issues, Milton Friedman. I'd like to thank Sally and the Pacific Research Institute for having organized the event to give me the opportunity. Let me say one comment before I make any remarks at all, because I may forget to say it later on, and that is that I believe that both the Canadian and U.S. healthcare systems are marvelous. I think both healthcare systems are the envy of the world in some respects, that we shouldn't forget when we're engaging in these conversations just how far we have come with healthcare. And I particularly want to say that the Canadian healthcare system, that I think we do, or we have had at least, a very good healthcare system, and that does provide a very good, generally speaking, a very good quality of care. by comparison with, for example, something like the UK healthcare system and others that one could mention. So I want to say that just by way of introduction, in case I forget. Now, there was something that Milton left out. When I began to look at the healthcare systems, Canadian, U.S. healthcare systems, and to do some sort of comparative analysis, I was struck with what I read in the journal. And I'm going to read some passages about the U.S. healthcare system that I read that perhaps give you a better indication of why there's such angst and why people are motivated to look for solutions. Census, I'm just going to read some random quotes here. The first is an abstract from the lead of an article. Census regions in urban D.C. were categorized into quintiles by percentage low income. Incidents of death were then qualified under these regions. Statistics from 1971 and 1986 censuses indicate that infant mortality decreased over this period. However, twice as many infant deaths occurred in the most poor areas as in the least poor areas in 1986. Amongst adults, those in the most poor areas had the shortest life expectancy, with males in the most poor areas living 6 years less than those in the least poor areas. Although survival to age 75 showed an increase between the two census years, 16.5% fewer men in the most poor areas than in the least poor areas survived to that age in 1986. Poverty remains associated with poor health. From a chart that is headed Racial Minority Persons Living in Dense Homogeneous Populations, Standardized Mortality Ratios. Infective and parasitic diseases. This is, by the way, standardized means relative to the average population. Infective and parasitic diseases, 2.8 times higher than the average. Diabetes mellitus, 2.16 times higher than the average. Alcohol psychosis and alcoholism, 3.97 times the average. Cerebrovascular disease, 1.39 times the average. Pneumonia, 2.92 times the average. Kidney disease, 2.04 times the average. Infant mortality. Infant mortality in racial minority group populations was investigated in 5 states for the period 1976 to 1983. Minority group neonatal mortality was over 1/3 higher than that experienced by the general population, while post-neonatal mortality was almost 4 times higher. Significantly elevated post-neonatal causes of death included infective and parasitic diseases, 11.8 times the average for the population. Pneumonia, 12.1 times the average for the population, and sudden infant death syndrome, 3.6 times the average. So I think that is one reason why there's a great deal of concern about your healthcare system in the United States, because of the outcomes that are produced in that sense. Now there's another, or a reason why you're looking for alternative kinds of healthcare systems to replace your healthcare system. Now we also have some data here. Now I'm pushing. Oh, there we go. Okay. Now, Milton, I brought with me the new and advanced version of the thing. You see, it's palm size. And by the way, it is a laser, so it enables me to do eye surgery. And any of you are thinking about falling asleep, so don't fall asleep, okay? Now, what this chart shows is, this is the only fuzzy one there. This had to be made up from a print, unfortunately. It's a bit fuzzy. This shows I'm sorry to lay all this history on you. Milton has already laid on considerable amount, but you know, even if, as Winston Churchill said, history is just one goddamn thing after another. even if that's true, and you can understand from poor Winston's point of view why he may have felt that, but even if it's true, you can still learn a lot from history. And this shows the history of the progress of the cost of the two healthcare systems, of the United States healthcare system, expressed as a percentage of GNP. Now, this is a very bad way in which to make this comparison, but it is the comparison that first attracted my attention to this whole issue. Because I saw this chart, and it does show that the cost of the U.S. healthcare system has gone up and up and up, and whereas Canadian healthcare system has more or less flattened out. Now, the interesting thing about it is that right back here, we introduced socialized medicine. Our so-called National Health Act was put into place, which offered the provinces bribes so that they would offer healthcare systems of a particular kind to their citizens. And it's not that dissimilar, I suppose, in some ways to the way in which you proceeded in the U.S. With your Medicare and Medicaid program. In any event, what people conclude, people from the U.S. and looking at all of the things that Milton has already pointed out, people from the U.S. looked at this data and I guess said, holy smokes. It looks like the Canadians, with their socialized, centrally directed healthcare system, have been able to control the cost of healthcare, whereas we in the United States, with our individualistic, more or less market-driven system, although with the important caveats that Milton's already pointed out, have not been able to control the cost of healthcare. Well, needless to say, somebody like myself, who happened upon this interest of people like President Kennedy, sends a shiver down your spine, doesn't it? To think of it, Senator Kennedy, rather, who I suppose I'm not supposed to make political comments in a foreign country, but that was a Freudian slip, which, in any event, he in the late 1970s began to draw attention to this comparison, and others since, Governor Dukakis drew attention to this and said, it's evident that the Canadians have solved the problem of healthcare explosion, the cost of healthcare explosion, and the reason is because they've adopted this socialized medicine. Well, I was struck by this because we've done an awful lot of work at the Fraser Institute on the comparative costs of systems. And we've examined now, and we have access to other studies, we must have several thousand studies comparing the comparative costs of delivery of services through the public sector and through the private sector. And there are just an incredible number of features of these different studies, but there isn't a single one of them, not one, that shows that a service which is produced without any competition, subject to monopoly supply, produces healthcare at a lower cost, or produces the service rather at a lower cost than the same service produced under competitive conditions. And that goes all the way from garbage production to garbage collection to airline service production. So when people told me that the Canadian healthcare system was producing healthcare at a lower cost because it was socialized, this attracted our attention. This would be the equivalent of finding the missing link in economics. I mean, this is the only case where we would have been able to discover this to be true. Well, then it dawned on me that, well, maybe that's the case, but maybe there is an alternative hypothesis. Given all this evidence we have on the superiority of the market in producing service, maybe there's another explanation for this divergence in cost that does not involve the superiority of monopoly-produced service. And the alternative hypothesis is that while Canada's public healthcare system is not more efficient in the sense that it produces individual services at a lower unit cost, it may be more efficient in the sense that it has been able to cap or control the total supply of healthcare resources. That, in that sense, that the total cost can be limited because, of course, don't forget, by now, since about 1972, all of the healthcare decisions in Canada are effectively made by 11 people: the Federal Minister of Health and the 10 provincial ministers of health. And they decide how much is going to be spent on healthcare. This is no longer a matter which is left to the vagaries of the marketplace or any other intelligent process. It's up to the politicians to decide how the money is going to be spent. And I say that, when I say intelligent, I mean in the sense that our evidence from all of these other studies show that if you give a politician sole and single control over anything from bridge construction to garbage collection, it will not be done entirely intelligently. It'll be done subject to the political process. I mean, that's not. I mean, maybe I'm being too strong with that, but you all know what I'm driving at. Well, So what we did was we looked at the, we then said, well, let's look at Canada and the U.S. from a structural point of view and see what might be going on here from the point of view of cost efficiency. Let's look first of all at the demand side of the market and see whether there are any peculiarities about the demand side of the market now that we have socialized medicine that would lead this cost performance to have evolved. To shed some light on whether, in fact, there is more efficient production of healthcare in Canada. Well, we found that the demand in both countries seems to be subject to exactly the same kind of forces. We found, for example, that patients in Canada, as well as in the United States, read the Reader's Digest. They therefore know what the latest medical technology is, and they demand it. They go to their physicians and they say they want a CAT scan, they want a kidney lithotripter instead of having it. They know about medical technology. And so we found that the demand from that point of view, the technology, the information that consumers have about healthcare seems to be about the same in both countries. We found that for most U.S. consumers, 90% of the healthcare bills in the United States are paid by third-party payers. They're not paid by the consumer. And therefore, the consumer in the United States, like in Canada, is not in any way impeded or not too much impeded by the immediate cost of the health care that they have to consume. In Canada, of course, we have completely removed the financial consideration, and that should make our demand a little more aggressive than your demand is in the United States. There are some differences in that U.S. healthcare consumers are more affluent, and we would therefore expect, with more affluence, than the same way that you demand more recreation on average than we do in Canada. Like you spend about 7% of your GNP on recreation, we spend about 4% because you're more affluent. For that reason, we would also expect you to demand somewhat more health care. However, a Royal Commission, when we were doing this research, we did discover a Royal Commission. Now, in Canada, Royal Commissions are appointed on the drop of a hat, really, but usually to investigate important issues of public policy, and they spend millions of dollars to find out the facts. Well, this Royal Commission in Canada concluded that the demand for health care in Canada appeared to be unlimited. Not surprising. I mean, there are no prices in the system. There are no financial inhibitions. The demand for health care appeared to be unlimited. Well, now you can see we're left with a real puzzle here as to explain why it is that the cost of health care is under control, seemingly, in Canada, where we have fewer inhibitions on the demand side than you have in the United States. We don't limit people's access to health care with financial considerations of any kind. The government itself concludes that the demand for health care is unlimited. Why is it that we find this control on the apparent control on the costs? And what are the consequences of that? Because as economists and as sensible people, we realize that if there's an unlimited demand and you then impose a restriction on the supply, which is what I mentioned at the outset, that this is one of the characteristics of our system, that the politicians can control the total amount of supply in the system, wouldn't you expect that to lead to rationing or other evidence that this is the way in which we control our total costs of health in Canada? So, as scientists interested in discovering which of these hypotheses are most likely to explain our situation, we went looking for evidence of the fact, and don't forget that in our system there aren't any prices, so when demand exceeds supply, the price can't rise. What has to happen is there has to be rationing. There isn't a price mechanism to ensure that the market's clear. There has to be rationing of what's available. So what we went looking for was evidence that there may be rationing in our system to see if there was any evidence. And of course there were anecdotes. We looked in the press first of all, and we did find the few stories about people not getting their heart surgery and things of that kind. But generally speaking, we didn't at the outset find a lot of clear evidence of until we found a hospital in a very small province, Prince Edward Island, which happened to have kept hospital waiting lists over the period 1983 to 1988. And you can see from this, this chart that over the period, at least in 1983, there had been a systematic increase in the total number of people waiting in this tiny province. Well, that was one piece of evidence that we found that seemed to suggest that at least in this province, waiting was that people were, that when patients came, instead of immediately getting access to the service they needed, they were told to wait. And of course, waiting is a method of rationing. If you don't get it, you don't get it, you don't get it, you're being rationed out of the system. Now this in some ways is an even more important. This piece of evidence we found in the province of British Columbia, and it was data on 13 different hospitals collected by the government in a lapse, I suppose, because we generally found that they're not interested, as we'll see later on, and I know some of you have already picked up a copy of our waiting list survey. Governments in Canada, for whatever reason, are not entirely interested in collecting evidence that there are problems with our healthcare system. I'm sure that your governments wouldn't be that way. What we have here is a very interesting. This was the chart, I guess, that really made me determined to go out and do some fairly sophisticated measurement, because in this chart we have the percentage of the total number of patients, and this is an ex post survey. This is where they go around. They find that patient X has now had their surgery, and they say, okay, how long has that patient X, having now had their surgery, waited on our lists? They can go back in their records and find when they first came on the list. And as you can see, this is for 13 different hospitals, and you find that there's a huge variation in the percentage of patients who waited longer than 16 weeks for their surgery. In one hospital, they waited nearly 45%, about 42% of the patients waited more than 16 weeks to get their surgery. Well, in this hospital, number one, less than 2% of the patients waited that long. So this tells us, unfortunately, the government wouldn't tell us where these hospitals were. So we couldn't do a very careful analysis to find out what the determinants of these different things were. They wouldn't tell us which hospitals, but it did make it clear to us that access in this one province of British Columbia, that access to hospital care varies very dramatically according to whether you're being tended to by this hospital or by hospital number 8. And so this sparked our interest, because we now had more or less, solid confirmation of the fact that rationing is being employed in the system to determine, to limit the supply, but secondly, it showed us that equal access is not being delivered under our system, which is one of the things you just take for granted in Canada, and unfortunately is talked about greatly in the United States at this moment. That you will solve your problem of access by adopting the Canadian healthcare system. Well, I don't know. This is a waiting list survey that we did for British Columbia for 1990, and those of you who are medically aware in the audience will know what these things are better than I do. But you can see that the shortest waiting time was 12 weeks for orthopedic surgery, and then we had things like cardiology. We had 24 weeks waiting periods for cardiology at that point. And I might tell you that this this is a mistake here. This turns out that data, this was the first survey we did, and we found out that there was an outlier in the data. There was a surgeon whose data was badly reported, and this unduly influenced the results. So don't pay any attention to that. When I first showed this to a group of physicians, they said, "Boy, you sure got strong bladders in Canada." You can wait for 24 weeks, you can wait forever, But anyway, so this is what we found for doing one survey. So again, we had a few problems because there was a nurses' strike just before we took this data. And so I was worried that this data wasn't completely accurate. So we said, well, let's go and do some real surveys. Let's survey a bunch of provinces, and let's resurvey British Columbia for 1991 and see what kind of data we get for that. Well, first of all, let's go across the provinces. We surveyed provinces in the very eastern part of Canada, Nova Scotia, New Brunswick, and Newfoundland. We surveyed one province in the middle, New Brunswick, and one on the west coast, British Columbia. I said the one in the middle is Manitoba. What did I say? New Brunswick? I beg your pardon. Manitoba is in the middle, yeah. New Brunswick, as Sally knows, is over on the east coast. Anyway, this is for Newfoundland, and you can see that, again, those are, even if you're not medically aware, by the way, this plastic surgery here is for restorative, it's not for like cosmetic purposes. This is the stuff that's medically covered. Under our healthcare system, cosmetic surgery is not covered, but restorative is. That would be like people who've had mastectomies and things of that kind, or who have had bad facial injuries and so on. Cardiology, as you can see in Newfoundland, 40 weeks is the waiting time for, this is bypass surgeries, generally speaking. We couldn't get any measurements for otolaryngology, or whatever that is. And orthopedics, about 14 weeks. Now I'm going to sort of flash you along to see some of the other provinces, just so that you know that these are not flukes. I mean, we didn't get bad measurements. We didn't, I mean, even if we had bad measurements, they are consistently bad, if you know what I mean. Plastic surgery, once again, very long in New Brunswick. Orthopedic surgery, about the same as Newfoundland. I caution you that the length of the axis up here changes from chart to chart, because I can't get the people who produce the slides to understand that people like to have consistency up here. So the aesthetics, they keep saying to me, but it's the aesthetics that count. Anyway, gynecology, a fairly lengthy list. Orthopedic surgery, once again, 12 to 14 weeks. Cardiology, now, New Brunswick has got a very low waiting period for cardiology. Well, it turns out that the reason for this is that they didn't have a heart-lung machine until last year, and so they weren't doing cardiac bypass surgery, and people weren't yet being referred, so they didn't have very much. And I also found out that I'll let you think I'm joking, but I'm not. I wish I was joking. But I also found out that our low waiting list here for ophthalmology in these provinces are in part due to the fact that they don't offer some new kind of surgeries also, which for cataract removal and things of that kind, which are available in other more affluent provinces. So, for example, here in Manitoba. Now, Manitoba has a much lower waiting list for plastic surgery, but orthopedic surgery is up in the same range, 15 to 20 weeks. Cardiology is much lower, about 14 to 15 weeks. Now we go to British Columbia, and as I suspected, the strike, the nurses' strike, 1991 nurses' strike, 1990 nurses' strike rather, did greatly distort the data. As you can see, much longer times were recorded in 1990 than in 1991, and so in almost every case, the green line, which is the 1991 result, is shorter. The waiting times are shorter than they were in 1990. Unfortunately, President Bush didn't have the 1991 survey and used the 1990 data when he made his comments about British Columbia, for which I got a lot of heck. You can imagine he was using data that was from the 1990 survey, which showed this kind of waiting list for cardiology, 25 weeks, 24 weeks, when in fact the waiting times are now only 14 weeks, as it was pointed out to me. Only 14 weeks you wait for bypass surgery in British Columbia. I'll come back to the notion of the strike and its impact in a few minutes, but I want to give you now some sense of the history. These are, you see, the aesthetics once again. These are much more important numbers than the other ones, obviously. They're much larger than, the charts are much larger than the other numbers. You see. This is a comparison. We were able to find, generally speaking, there is not data available for long periods of time in Canada on this hospital waiting list thing, so we couldn't make a comparison over a long period of time. We were, however, able to find one government study, which was done in 1967, preparatory to the construction of a new hospital, where they had done a waiting list to find out how many people were waiting. And at that time, about 0.6% of the population of the province were waiting. Just over 0.5% of the population of British Columbia was waiting for surgery. Now it's nearly 1%, nearly 0.9% of the population waiting. So we have had a significant increase in the number or the percentage of the population of British Columbia who are waiting now for surgeries. And I think this is an important thing to take into account, because don't forget, 1967 was a period just before we got socialized medicine. We had some aspects of socialized medicine. We had socialization of the hospital system, but not of the general healthcare apparatus. And as you can see, we've had an increase, at least since that time. How's the horizontal neurosis? Are you still hanging in there with me? Or you know, when people there's a disease that comes to people when they're listening to lectures about healthcare economics. I found, I call it horizontal neurosis. Certain glazing of the eyeball, and then, you know, the old eyelid muscles won't work anymore, and then the head muscles start to go. Well, I'll try and hang in there. Just a few more charts, and we'll get to the punchline, as it were. So try and hold in there. Now these give the data. You probably can't see them back there in the back, but that's what you get for sitting in the back row. The people who are sitting up front can see that all of the charts here are together. Now, if you look at this first chart here, for example, it says that average weeks waited by specialty, that in Newfoundland, which has got an income which is much lower than the average income in British Columbia, for example, there are two possible hypotheses why you have to wait for a lot longer in Newfoundland for plastic surgery. One is that they're a lot uglier in Newfoundland. Right? No, that may be true of New Brunswick, but I'm from Newfoundland, so it's certainly not true of Newfoundland. No. Not ugliness, no. What explains this? What explains the fact that Manitoba and British Columbia, both relatively affluent provinces, have short waiting lists for plastic surgery and for cardiology and for any number of the others? There are some here which don't follow that pattern, but it is generally true that the low-income provinces in Canada have longer waiting lists than the other waiting lists. Now, that seems to me to be explained, you know, it's consistent with the hypothesis that you have fewer resources to allocate in the public sector in a low-income province, you do less surgery, and so people get rationed more. That's consistent with the hypothesis that we're testing, and you would expect to find more rationing in poor provinces than you would in the more affluent ones. And we see the total numbers of patients waiting. Of course, the total numbers of patients waiting are not, because these are provinces that are of different sizes. The interesting thing is that what we find now is that there are roughly 261,000 people waiting Canada overall, waiting for surgeries of one kind or another, about 1% of the Canadian population. And this shows the total numbers that we estimate for the different specialties. And you can see there are a couple that really stand out. Ophthalmology is one where a lot of people are apparently waiting, and that's because of this new technology. Orthopedic surgery, cardiology, the numbers waiting are not large, but of course, as we've noted, there's a limited capacity to do that kind of surgery. Now, here's a chart which I just discovered. Economists, when they're talking about forecasting, they always say, give people a number or give them a date, but never give them both. Well, my research assistant took me literally and didn't put any dates on the bottom of the chart. This is for England and Wales. This shows take my word for it, honest. Honest, this shows the number of thousands of people waiting in England and Wales over a period from roughly the inception of the National Healthcare Service in Britain to the mid-1980s. 1986 is the last date, I believe. And it so happens that that number is more or less comparable to our figure in Canada in the sense that, in what sense? Well, if we look at if you look at it, that's what I just said is wrong. Right there. What is true is if you take 20 years from the inception of the National Health Service and you compare the British healthcare system with the Canadian healthcare system after 20 years, you discover that in the UK healthcare system, there are 1.3% of the British population waiting for surgery. In the Canadian healthcare system, we find 1% of the people waiting for surgery. So that in the orders of magnitude that we're measuring here, that's a roughly similar kind of outcome. They're obviously somewhat worse in Britain than we are, at least they were 20 years into their system, but we're following a path which is not very different. And I think it is important to make these kind of comparisons, because how else do you know when a problem is likely to get serious? I mean, what is a serious waiting problem? How many people do you have waiting before you say, yep, we've really got a problem with our system? I think we are rapidly approaching the situation in Canada where rationing is now beginning to have a very definite impact on the quality of care. Now, I promised to go back to the strike in British Columbia, and I want to go back to the strike for a number of reasons. One, because it shows some very interesting lessons about what happens when you have a monopolized, single-payer healthcare system. First of all, of course, if you have a single-payer, monopolized system, that system can be shut down if you have a strike by one of the suppliers to that system. Now, in the case of healthcare in Canada, we typically have one monopoly supplier of nursing services, one monopoly supplier of hospital care worker services, and they negotiate with the governments about how much they should be paid. When they can't come to an agreement about how much they should be paid, they shut the system down. Now, some of you are thinking, well, that couldn't ever happen here, because your public servants aren't allowed to strike. But don't forget that you currently have a privately run healthcare system. And those workers currently have the right to strike. The only difference is, and I have nothing against the right of workers to make whatever deals they want with their employers. However, when you create a monopoly, you then pass over to that union the ability, literally, to hold you up for ransom in the process of negotiating their wages. Now, I'll show you some figures later on to show you what has happened historically in regard to that. But what I want to focus on here is what happens when you have first of all a slowdown in worker slowdown in the heart-lung machines, where the nurses start working to rule, and then finally shut the system down. This is the number of procedures performed. Don't forget, this is quarterly data. The strike that happened in 1989 happened for only 16 days. But it shut down the whole system for 16 days. For a period before that, it slowed down the system. So you had this very rapid decline in the ability to do coronary bypass surgery in the province of British Columbia. The green line is the demand for procedures, and that carries on irrespective of the strike. And people's hearts don't know that they have to stop or have to not stop during a strike. What am I saying? And so you have this widening gap between the ability to do surgery and the number of people who want it. The result is that when you have a strike, or you have some interruption in service, you find that you get a quantum jump in the number of people who are waiting, and it stays up there. Because just because you go back to work and you start now to work your 8-hour days or 12-hour days, whatever it is they work in the cardiac units, you only have so many heart-lung machines. You only have so many heart surgeons. You only have so many perfusionists who can operate the heart-lung machine. The consequence is that it's very difficult to recover. And the way in which we recovered in British Columbia from this, well, we did two things. One, we opened a new heart surgery unit in one of the hospitals, and that did part of it. But we contracted out for 200 bypass surgeries with hospitals in Seattle. Now, of course, you have to ask yourself the obvious question: if you're going to duplicate this system, where are you going to go if it seems almost too obvious to point it out. But the important point about all of this, so I show you what the consequences of a work stoppage are and of shutting down the system are. Now look at what's been happening to the amount of friction in our healthcare system in terms of the likelihood of there being a strike. This is the number of days lost due to work stoppages in healthcare in Canada. You can see, starting back from the beginning, there were almost none. By the way, the yellow line, or whatever color that is the actual days lost, and the green part is the 5-year moving average. And as you can see, whereas at the beginning there was no friction, because in the beginning we had lots of money. In the beginning, the governments gave in to the healthcare workers. Every time they wanted something new, they got it. When they wanted a bigger settlement, they got it, and so on. And it wasn't until the mid-'80s that we began to have, we had one disturbance back here, which I've forgotten. No, that was a strike on principle, I guess, in one of the provinces. We still do have them occasionally between labor and the governments. And here we have the increasing friction as our governments, with fewer and fewer resources, are not able to give in. More and more strikes are being precipitated. There is now, as we talk, the Hospital Workers Union in the province of British Columbia, in all probability, has shut down the British Columbia healthcare system once again over a wage dispute. I haven't been talking to anybody this morning, but that was the latest news that I got last night. Well, ladies and gentlemen, what should be your conclusions? I've gone on longer than I should have, and I've used up some of Milton's time. But what are the lessons to be drawn from all of this? Well, first of all, what is the lesson to be drawn on minority and low-income populations? I have a confession to make. You know all that stuff I read to you at the beginning, all those journal abstracts that I read to you about infant mortality? And they weren't American. They were Canadian. And I did change BC to DC when I talked about the incidence of infant mortality amongst low-income parts of our population. And when I talked about lower life expectancy in low-income parts of our population, I changed the B to a D. The reality is that you are not going to solve generic problems of that kind by overhauling your healthcare system. You aren't even going to solve it in the sort of primitive way that you're going to be able to assure equal access in the grossest sense. I've showed you the data across provinces. I've read to you the data across income deciles within the same city in Canada. I've read to you data about how our Aboriginal population has infant mortality statistics and infant death statistics and neonatal and postnatal death statistics, which are tragically higher than the overall population. Those problems are not going to be solved by overhauling your healthcare system. So that's the number one. The second problem is, of course, that we in Canada haven't, or the second inference is that we haven't solved the problem of access. We are now systematically substituting rationing for the delivery of care in order to control costs. We are going to do more of that as time goes by. We are faced with a potential doubling of our total budgetary allocation to health care because of the aging of our population, which at the moment is younger than the U.S. population, by the way. We are faced with a doubling by most recent calculations, and that is something that is not going to happen. Because in order for that to happen, our wonderful politicians are going to have to sit around and decide, well, we aren't going to pave any roads in your jurisdiction, Fred, and we aren't going to build any more bridges in your jurisdiction, Sally, and we aren't going to do all those things that you want to have in your particular portfolio, George. It just isn't going to happen. So we are going to follow, it seems to me, at least the evidence seems to suggest that we are following the British route, the controlling access to health care, the controlling cost, rather, of health care by limiting access, systematically limiting access by rationing. On reducing wasteful duplication, I once saw a PBS documentary by Walter Cronkite, a person with whom I grew up, it seemed, and a person for whom I had a high degree of respect as a journalist and so on, and I'm sure that he didn't mean to mislead people. But he showed in this program called Borderline Medicine all these sheafs of duplicative paper that were chasing around this poor patient through the U.S. healthcare system. And he, just like many learned people and academics, are suggesting that the way in which you should solve this is to go to a single-payer system. That you will eliminate the duplication, you will eliminate the costs of that, and in fact you will eliminate your costs to such an extent that you will be able to pay for all those 30 million people who are alleged not to have any health care insurance, or 37, whatever the number of the week is. It seems to change from according to who you listen to and but somewhere between 30 and 40 million people. Well, you know what's interesting? If I came down, and I know that where this idea comes from is the Canadians who come down and show you all of the ways in which we have eliminated the administrative costs of our system by having only one payer. But if I came down from Canada and I told you that you could eliminate the costs of having all those duplications of having multiple car dealers, that your automobiles would be a lot cheaper, and that you'd have a lot better quality of automobile if only you did away with all those automobile dealerships. Just think of all the paperwork that's involved in the multiplicity of suppliers of automobiles. Now, you would laugh me off the stage if I told you that. But nevertheless, people come down and they tell you that about our monopoly healthcare system in Canada and how we've eliminated all this duplication of costs, and people accept them as gurus. But this is the consequence. A monopoly healthcare system has the instability of all monopolies that can be withdrawn, and, as I've pointed out, has a questionable quality of care. Well, what is the final conclusion? I think the final conclusion is that if I were an American trying to cope with the problems, and I know that there are problems in your healthcare system, nobody can deny it. Milton has pointed out some of the economic problems. I think there are also other problems, distributional problems, and so on. If I were in your position, I wouldn't make the assumption that the Canadian healthcare system has got the solution. In fact, nobody has got the solution. And that, just like in the case of bubble gum and automobiles and everything else, you're destined to grope for better ways of coping. But if I were in your position, what I would be asking myself is, what are the problems in your system that are induced by the regulatory system? What are some of the problems that are induced in your system by government itself? Because, as I say, we find in Canada that typically when government gets involved in the production of a service, increased costs are the consequence and reduced quality are the consequence. And I'm now going to turn it back to Milton, who I know is going to tell you what the solution is relative to that. Thanks very much for your attention.
Mike says he's used up some of my time, and of course, as you know, we all believe in a price system, so how much are you going to pay me for the time of mine? Same price I'm getting for the rest of it.
So I'll pay double.
You'll double it. You know, Mike's told a very interesting story about Canada. That's not a solution. One of the things that always fascinates me, and in various areas, you come up to one area after another in which the U.S. has problems. One of them is health care, and I'm going to come back to that in a moment. Another one of them is education. Another one is crime, which derives from the drug issue. And almost everybody who discusses those, discusses each one as if it was a problem by itself and had no relation to the other. I go to the Drug Policy Foundation in Washington, and I have a whole room of people, all of whom think it's terrible what government is doing in drugs, but it's wonderful what government is doing in everything else. You go to a room of physicians, and they'll think it's terrible what government is doing in medicine, but, oh, what government is doing about something else, maybe, about housing, or about controlling population or something, or about the environment, that's fine. But that's the point that Mike was getting at the end. You really want to look beyond the individual problem to the fundamental problem, to what is the source of it. I'm going to make a statement that some of you will find absurd, but I challenge you to find a major exception. There is not a major problem in the United States today that does not derive from excessive government interference in spending. Our educational system is in a mess. We now spend 3 times per child in real terms as we did 30 or 40 years ago, and nobody will say that the quality of education has gone up. Why? Because government is spending too much money on it. Because government ought not to be in that business. That's why some of us have worked to are trying to put a voucher initiative on the ballot in California. I hope all of you will find out about it, support it, and sign the petitions for it. But let me come back to medicine. The problem in medicine is not that we're spending too little money. The problem is we're spending too much, but we're spending it very badly. As Mike said, we do have an excellent medical system that in the sense that excellent medical care is available. But it's no wonder that poor people are getting shortchanged. If it costs you 26 times as much in real terms per day in a hospital, and the ratio is not far away from that for medical care, if moreover you are depending on the same people to provide you medical care that you're depending on to handle your mail, it seems to me little wonder that we have real problems, even though on a private level we have essentially the best and most advanced medical system in the world. There's only one way to solve it, and that's the same in all of these fields. It's not that we have a separate solution for drugs, and a separate solution for education, and a separate solution for health care, and a separate solution for not enough capacity on the airports, and so on down the line. There's a single solution to all of them. Privatize, privatize, privatize. Surely, if we hadn't known that lesson before, we should have learned it from Eastern Europe. But we have not. Now let's get to health. How do we privatize, and what does that mean? In the first place, there's enormous confusion between two ideas of government involvement. One is the provision of money, the financing, and the other is the administration of the service that the money is intended to buy. The U.S. government gives people food stamps. But the U.S. government does not run the groceries at which the food stamps are spent. It doesn't set the prices at which the various foods in the store should be sold. Now, the solution, it seems to me, that's right for medical care is let's, for the moment, separate the two issues of financing and administration. Personally, I may say I'm a radical, and I would believe that the government ought to be spending, that the only financing the government ought to do on medical care is to help the truly indigent. But that's an extreme view, and I'm not going to press it at all. I'm going to take a position that I think is a halfway house because it's at least on the right road. The major problem, the problem that bothers people about health care, is not what they do when they have a cold. The problem is when they have a major expenditure facing them. And that is really a cause of catastrophe for everybody. Every one of us is in the position of fearing that something will come along that will really be a major catastrophe. And so I propose that we restrict, in the main, government financing to providing catastrophe insurance, major medical insurance. I propose that what we really do is, number one, we completely abolish Medicare and Medicaid. Those are the administrative processes. They're like running the groceries would be for food stamps. Number two, that we eliminate one other factor that has been a source of great trouble, and that is the treatment of employer-provided medical care as a fringe benefit not subject to taxes. Now, you know, it's a very interesting thing how these things come in. Why do you suppose we have that practice now? You don't know, and I'll tell you. I believe. I'm trying to check up more on this. I'm not absolutely certain. And I've been trying to investigate where it originated. And my understanding is that it originated at the end of World War II as a result of another government policy, namely wage control. The government had price and wage control. It was fixing wages. And employers were therefore, but it was printing money, so you were having inflationary pressure. And employers were having a hard time keeping their workers or encouraging them or finding workers. And so employers were looking for ways in which they could get around the wage control. And so they were offering fringe benefits. And I don't quite know how they got the government to rule that the fringe benefit of medical care was not going to be treated as taxable. But at the time, only the cash payments were taxed. And that practice started then, and once you get something, see, the problem with government is not the things it does, but the fact that you can't get rid of the mistakes. And once you get a thing in there, that's it. You only need one hand, and only part of that hand, to count the number of occasions on which government programs have been terminated. So we go back. Why do I think that's a very critical thing? Because there's no reason in there's no reason in the world why we should get our medical care through our employers. We don't get our food through our employers. We don't get our housing through our employers. The employees in the Soviet Union did. But why should we get our medical care through our employers? Wouldn't everyone in this room rather be in the same economic position but handling his medical care directly? As it is, when the employer provides it, and it's tax exempt, it has two features. In the first place, we as individuals have no reason to keep down the cost. We'll take the most expensive plan the employer offers. And second, in the process of bargaining for wages and so on, medical care will come to constitute a larger fraction of total wages than it otherwise would. And so if we eliminated the deductibility of, if we eliminated the non-taxability of that fringe benefit, and instead lowered the average tax rate enough so that there'd be no increase in revenue, I don't want to have the government have any more money out of it. Heaven forbid. If we did that, then employers could still offer medical care, but not as a fringe benefit. It would be the cost of it would then be included in the worker's wages, and he would have to pay a tax on it. And very soon, workers would decide they'd rather take care of their medical benefits themselves. See, I want to privatize right back to the individual consumer who ought to be the boss. So my very simple and superficial program has these following steps. Number one, eliminate the tax exemption of medical care, of that fringe benefit. Number two, abolish Medicare and Medicaid. Number three, require every individual in the United States to have a major medical insurance program with a large deductible. And number four, and this is where I really would not like to go, but I don't want to get involved in that argument, let the government pay for that major medical care. Provide everybody a free major medical care with a deductible of something like, I have proposed something like $20,000 a year, or 20% of a person's income, whichever is lower. So that the major medical care proposal solves the problem for low-income people along those lines as the other. As I say, in principle, what the most you ought to do is to require everybody to have one. You ought not even to do that, but that's as far as you ought to go. And then you ought to finance it only for those who are truly indigent. But, as I say, I have no doubt that what I'm describing would drastically lower the total cost of medical care. Private individuals would also be able to establish a personal relationship with their physicians of the kind they don't have now. And physicians would be able to operate without filling in all those pieces of paper. You would have a human system of medical care instead of the kind of mechanized, paper-driven, inhuman system that you have now. And total cost would be drastically less. My guess is that private costs for medical care would return to the 4 or 5% of national income range that they were for decades. That in addition, so far as the cost of the major medical is concerned, it would be a substantial sum, but very much less than the hundreds of billions of dollars that government is now spending on administering this complex and crazy system. Well, that's my proposal for you. The crazy proposal. It hasn't got a chance in the world of being adopted. Why doesn't it have a chance in the world of being adopted? Almost everybody would benefit from it. The problem of the poor would be of the absence of medical care for the poor would be eliminated. The problem of excessive burdens on taxpayers would be eliminated. The problem of paperwork would be eliminated. the physicians would be better off. But the tens of thousands of people, the hundreds of thousands of people who are now employed in the state medical care system would not be better off. The congressmen and their employees would think they would not be better off. The vested interest in the present system would make it exceedingly difficult to get so radical a proposal adopted. And again, I come back to the point I came back at the beginning. This is not a problem of medicine alone. It's a problem of too big, too intrusive, too large a government, which is now becoming a self-generating monstrosity which the people cannot control. The people have nothing to say about what goes on. You know, people are always saying, well, the reason it's such a big government is that people demand services and they're not willing to pay for it. That's a bunch of nonsense. Nobody will tell me that the consumers of the United States want to pay twice the world price for sugar. Nobody will tell me that the buyers of automobiles in the United States really wanted the government to follow a policy with respect to imports of automobiles that raised the price of every automobile bought in the United States by about $2,000. You really think that could have gotten the popular vote on a referendum? You can go down the line and you'll find one thing after another in the same category. So for medical care, as for all of the rest, I say, unless we can find some way to privatize it, we're not going to get very far on the subject. There's no other way of doing it. There's no use kidding yourself. Thank you.
I would like to thank both of our speakers for excellent and thought-provoking presentations. I would now like to introduce Stephen Hayward, who is the Research and Editorial Director of Pacific Research Institute. He is going to serve as our interlocutor, and he will be coordinating the questions from the audience. So if you have a question, if you could raise your hand, and Stephen will come by with the microphone and take you, and he'll probably start on this side and then move to the other side because it's too time-consuming to move side to side.
Right.
So go, Steve.
Thank you, Sally. Since it's the afternoon, we thought we'd do this afternoon talk show style. So I'll go this way for a while first and then over there. And I'm especially interested in having some questions from people in the healthcare delivery profession who may have a particular insight on the presentations today. Someone around here? Yeah.
I have a question on what is Mr. Walker's advice to politicians? Glorifying the Canadian system without even explaining to the people that research United States spending a lot more than Canada. Also, if you do all the waiting, the people in the waiting list, if you make it current and there's no waiting period on, waiting list on the surgery or medical care that they need, what will be the difference between your 9% and our 12% of national growth? And what is your advice to Senator Ted Kennedy?
Well, there are a whole host of reasons why the comparison of the costs of the Canadian and U.S. healthcare system as they're typically presented are not accurate. One of them is the fact that we do considerably less research in Canada, as you pointed out. There's also the fact that most Canadian hospitals, of course, are now publicly owned, and therefore there is no cost of capital contained in the Canadian figures. Now, there is some cost of capital involved in the American figures, although it's not complete in the sense that many of your hospitals also are owned by nonprofit entities, and therefore they don't have a charge for capital. But there are a number of reasons why the figures as they are normally presented should not be compared in that way. I guess my advice, not only to Senator Kennedy, but to anybody who looks at the Canadian healthcare system, is to do so with, first of all, with skepticism, to ask, well, what are their problems? You know, instead of assuming that we have solved all the problems, ask what are our problems. And I've tried to show you today what our modest amount of research has shown to be some of the problems that we have encountered relative to our belief now that rationing is the way in which we control the cost of health care in Canada. That we have not, in fact, solved the problem of delivering health care at a lower unit cost. We have solved the problem by mandating what the level of total expense will be, and with an explosive demand, that means that you're rationing access to health care. And that implies that people who are talking about single-payer systems or other ways of approaching the American healthcare problem, that this will reduce the cost of healthcare, that you have to recognize that there is a companion to that, namely a reduction in the supply of service. And some people are quite aware of that. You know, I mean, some of the political advocates in the United States are aware of that, and they're saying, well, that's a choice that we would like to make. Now, I don't know if it's a choice, as Milton said, whether if you ask individual Americans if that's the choice they would like to make, but they may not get such a choice. That's the unfortunate problem. But I would say look at our system skeptically and look at it in the light of the kind of research that we're now doing about what some of the problems are.
Michael, I'm going to use my executive prerogative to ask a follow-up question to that for both of you. Because the U.S. spends such a great amount of money in medical research and other countries do not because of the way they're organized, to what extent is it fair to say that other nations' health care is subsidized by our medical research? And if it is fair to say that, how significant do you think that is?
Well, our health care is subsidized by the medical research of other countries. And indeed, I'm not sure which way the balance of payments goes that way. For example, thanks to the inefficiency of another government agency, the FDA, we are far behind most other countries of the world in introducing new drugs. There's a much longer lag. Some years back when I looked into this carefully, in the case of heart, which we seem all be interested in, I've had 2 bypass surgeries, and I can assure you I would not like to have waited 40 weeks for one of those. In fact, I wouldn't be here if I had, and that's for sure. But in that case, the various beta blockers, various heart drugs, were about 10 years later being introduced and approved for use in the United States than they were in Britain, Canada, and elsewhere. But we benefited from the fact that there was a market there which enabled the pharmaceutical companies to develop them and to keep them going. So I don't know which way that balance of payments would be. I think that's a very difficult question.
If I could just add a footnote to that. First of all, a lot of the advanced technology that you have in the United States, the much ballyhooed magnetic resonance imager, for example, was invented in Britain. When your candidate, the Democratic candidate, Mr. Tsongas, was asked about the Canadian healthcare system, he said, well, if I had depended on the Canadian healthcare system, I'd be dead because the bone marrow transplant that I got was developed here in the United States. Well, the next day in the Canadian newspapers, a research scientist in Canada was quick to point out that that was untrue, that a key element of the bone marrow transplant procedure was invented in Canada. So where am I going with this? Well, the point is that if Mr. Tsongas had lived in Canada, he still wouldn't have got his bone marrow transplant, because research is one thing, access to research and access to medical technology is completely a different thing. So the average resident of Britain, where the MRI was invented, for example, has far inferior access to the MRI than you do in the United States, and we in Canada have far inferior access to the MRI than you do in the United States. So I think that while it's true that probably more research effort is expended in the healthcare system in the United States than anywhere else in the world, I don't think that that's the relevant point. I think the relevant point is that because you are not subject to the judgment of 11 people, or in the case of Britain, 1 or 2 people, as to what research you're going to have practically access to. Because don't forget, when a government decides to control total access to the healthcare system, they don't do so just in a blanket way. They decide, well, we're not going to have any more marrow transplants this week, or we're not going to have any more, this is for this month, or whatever. I mean, they have to make actual choices about what you're not going to get access to. And this I think, is the relevant question when you're comparing systems, is to look at access to high-tech medicine.
It's Richard Chirazala. My question is addressed to Dr. Friedman on your privatization of medical care. Have you thought about a methodology or something which you could do on an incremental basis, because political processes are very short-term and short-sighted, and what you're proposing is a very long-term and not a politically, I would say, a beneficial, quick reinforcement. Quick reinforcement that most politicians want is a really very quick reinforcement and the quick producer, but yours is a very long-term. So is there any incremental solutions that you've have for this? And my second part of this question would be have you thought about addressing issues with regards to making people more accountable to themselves as to their own physical well-being?
I'm not sure about the latter part of your question, but on the first part, I agree with you. This is not a quick fix. It would be a quick fix if it were enacted overnight, but it's not going to be enacted overnight. So I agree, this is not a quick fix. I do not believe there is a quick fix. However, I think there are some steps that could be taken which would improve the situation very greatly. One of those steps would be to remove the tax exemption of fringe benefits, and that's not an impossible thing to have happen. Another thing that is developing very extensively is a tendency for employers on their own, independently of the government. I think there are tendencies at work in the system reacting against these enormous costs that are likely to produce some improvements, particularly what's called the managed care approach by the large corporations. See, people talk about single-payer systems as if that means a government system. It doesn't mean that at all. There's nothing to prevent an HMO to which people individually pay a single price for a year, in which then a HMO becomes a single payer. By single payer, in this case, they pay the anesthetist, they pay the surgeon, they pay the other fellow. So you can have private single-payer systems. We have many such systems without. But I agree with you. I don't really think there are any very close. I really have no good suggestions. As I say, I'm not an expert on medical care. If you really want these marginal improvements, you want to go to a person like Alan Enthoven, who has been spending years in studying the details of this, and he will give you some very sensible short-term proposals. But they run up against the same problem of the vested interest. I think you're at least as likely to get a sensible long-term solution as you are a short-term. And both are going to require a fundamental change in the political structure.
May I just add a comment to that, and that is when I use the term single-payer system, I use it in the context of those people who are proposing, for example, in some of your states, that you in fact go to a megalithic supplier of one payer literally across a whole state, not something like an HMO, which I think is really just one aspect of one particular selection in a competitive market system. I was referring to monopoly control over the whole system when I use the term single payer.
I want to tell you a little story that came to my way because I think it's interesting about how private solutions sometimes can work. I have been in correspondence with a physician in another part of the country that I don't even remember where he came from, who has on his own followed refused to cooperate in any way with Medicare or Medicaid. He's operating as a private individual. And he's done this by getting a group of his patients and some employers to take out major medical insurance programs coverage, take the difference between the premium on that and the full coverage that they were having before, depositing that in a bank as a sort of a private medical fund, and then coming to him for service on an individual basis, paying for private fee-for-payment service. And he's guaranteeing them that it won't cost them any more than what they've got in that account. And they're ending up making money, and he's making more money. So don't underrate the ingenuity of the private market in getting around this. As you know, there's been an enormous growth of private enterprise in providing hospital services. And that's been putting the so-called nonprofit hospitals under very great pressure to be as efficient as are some of these private suppliers. So look, the miracle of America, in my opinion, is that with less than 50% of the total resources of the country at its disposal, our private market system can produce a level of living that's the envy of the world. So I don't underrate the possibility of people finding ways to make some money out of curing the medical system.
Dr. Friedman, my name's Phil O'Lone. First of all, to paraphrase Mark Twain, I guess I'm amazed how much smarter you've gotten as I've gotten older. But I'm curious about, you're talking about purchasing health care more or less on a retail sense. Would this involve some sort of a caveat emptor regarding negligence and malpractice?
Oh, well, that's a very interesting question.
And
sure.
as also, do they have similar problems in Canada? And as a secondary, sort of an incremental step, would you, as a, I assume, a Medicare recipient, be in favor of means testing for Medicare?
I'm in favor of abolishing Medicare. Well, but my proposal is the equivalent of means testing for Medicare. Because it says that the government's going to provide you with a medical insurance program, which will have a deductible, which will be less the lower your income. So that's really quite very much the now. Let's go back to the other question on malpractice, because that's a very interesting case. And there the problem is a very different one. It has to do with the way the courts will enforce the law, force things, contracts. You see, what happens today when you go to a physician is that you buy two things. If you go to a private physician or any kind of or hospital, you buy medical care and you buy a lottery ticket. And the lottery ticket has gotten increasingly expensive as malpractice awards have gone to the sky. And now the solution to that is obvious. Your physician says to you, look, I'll offer you these two things separately. I'll unbundle. If you only want medical care, and if you will sign a piece of paper saying that you commit yourself not to suing me for malpractice, my fee will be X. If you want me to be able to sue me for malpractice, fine, then my fee will be Y. A higher sum, and the difference will be the cost of the lottery ticket to you. Unfortunately, I am told by lawyers that no court in the United States today would enforce such a contract. Now, that's absurd that it should, but I'm told that that's a fact, and that's a major obstacle. Now, Mike will tell you the other kind of a solution to that problem, which Canada has.
Well, the other way, of course, is to limit the payoff in the lottery. And that is, in fact, what we have done in Canada. The Supreme Court of Canada in 1978 passed in effect, judgment that in Canada, in our system of precedent, is taken as law then by the other courts in passing of their judgments, that the award for pain and suffering, that's distinct from the award that somebody, if somebody loses a leg because of malpractice, let's say, they can sue for loss of income, they can sue for cost of future care that they may require, and then they get a reward for pain and suffering that was induced by this malpractice. Well, in Canada, that malpractice has been capped at a sum of $100,000 in 1978, escalated to the rate of inflation over the period since 1978. And that does two things, of course. It means that a specialist in Canada who is trying to protect him or herself from medical malpractice has to pay a sum of only about $10,000 as compared to something like $110,000 in the United States for comparable coverage. Well, that's the principal implication is that the overall settlement that can be given is limited, and therefore the cost of malpractice is reduced. Cost of malpractice insurance is reduced.
Both of you, I'm Bob Goldman from Golden Gate University. It seems that we have that lottery already called binding arbitration, and I thought that you might be interested to know it works pretty well. I have a question for you on the structure you alluded to earlier, and that's the nonprofit status of so many of our hospitals. Are you in favor of retaining that And is nonprofit status still in existence in Canada? Thank you.
My own position on nonprofit is very simple, straightforward, and extreme. I think there ought to be no nonprofit institution. That is to say, I don't mean there ought to be no nonprofit. There ought to be no exemptions from tax for any institution, whatever it is. Churches, universities, all ought to be subject to tax. I'm in favor of abolishing non-taxable income. Because what you do, what we have done in the country, this country, is to set up a class of institutions that have an enormous bias in favor of increasing government spending. They get the benefit of the increased spending and they don't have to pay any of the cost. Now their employees and workers do, of course, indirectly, but as of themselves they don't. So my position on nonprofit institutions is very straightforward. There's no reason why they shouldn't be organized on a nonprofit basis from the people who organize them. But they ought not to be tax exempt. There ought to be no tax exempt institutions. And that would solve the problem, any problem that raised with nonprofit institutions. Because, of course, a large fraction of all nonprofit institutions are nonprofit in name only. They are non-taxable, but the people who run them do not live an austere monastic life. You might ask the president, the ex-president of the university I'm connected with about that.
So we have time for just one more question. So.
Do you want the question about the nonprofits in Canada? First of all, I'm astounded. I'm astounded, Milton, that you would say that I thought you were against the corporate tax.
Of course.
Yeah. Well, what's your...
I want them all treated alike.
Right. No institution should be subject to tax. Only people bear taxes.
Absolutely.
Therefore, only people should pay taxes.
Yeah, but no institution should be exempt from tax if other institutions are subject to tax.
Right. So cooperatives, for example, who distribute, in effect, to their members, and then the members get taxes, is probably an interesting way to approach that. But there aren't any private... If your question was, are there nonprofit hospitals in Canada? There are no now private hospitals in Canada. There are some for extended care. There are very few private clinics that are operated on a profit basis for breakdowns in the public system, for example, for cataract surgery and a few things like that, hernia repair. There are a few private systems that can still operate. But basically, our whole system now is controlled and financed by the government sector. So the notion of a nonprofit now is just it's a curiosity from a historic point.
Dr. Friedman, my name is George O'Brien. Basically two questions. One is I was surprised that you did not mention the workers' compensation system. And the second, I'm wondering if you have any thoughts on the fact that a very large percentage of the money which is spent on people tends to go in the last 3 to 6 months of their lives. And I was wondering if perhaps one of the ways the Canadians solve the problem of spending large amounts of money on heroic methods is to simply send the people home to die rather than have them die in the hospitals.
I don't know anything about, I really did not mention workers' compensation because I'm utterly ignorant about the problems it raises, and I really have nothing to contribute on that. On the second part of it, I haven't, it certainly is undoubtedly true that is a source of a considerable, of an undue fraction of our spending of the last few months of life. Obviously, like I'm sure so many of you, I believe that patients should have the capacity to have living wills and the like that prevent such measures at their wish. But beyond that, the problem is not that so much is spent on the last few months of life. It's that so much of other people's money is spent on the last few years of life. And there's nothing wrong under the kind of system I was describing. Probably a very large fraction of medical care would go into that way too. But it would be fundamentally people's own money, except as the catastrophic medical insurance plugged into the system.
On workers' compensation, we, the Fraser Institute, have sponsored a bi-national comparative study of workers' compensation, unemployment insurance, and worker disability insurance, that is retirement disability pensions between Canada and the United States. That study, a comparative study, will be published in the Journal of Labor Economics in the a special June edition. Unfortunately, I don't know what the details of that comparison are, but if you're interested in it, that you can get it there. I would just like to add, finally, to what Milton said about the heroic efforts. It does seem to me that there are an awful lot of misleading statistics kicking around in the healthcare area, and that has got to be one of them. Because if you're involved in an automobile accident, then you hope that it isn't going to be the last few weeks of your life. But if in fact you are, or if you are shot at age 16 by somebody who holds up a liquor store or whatever, all of the health care expenditures that are made on your behalf are going to be made in the last few weeks of your life. That is a very misleading number, and I don't know why people continuously drag it up, and nobody seems to say, well, what do you expect? Now, for that portion of the population who are over 65, and who are in extremis from the point of view of age, that's a question, and there is the living will, and there are other things about that. But just to take those numbers about the money spent in the last few weeks of your life is a very, very misleading number.
Milton, would you like to make a final 1-minute comment?
No, I've made many final 1-minute comments already. Why another?
Right, do you have any final comment?
Well, I guess just once again to say that although I've come here today as a critic of the Canadian healthcare system, I want you to know that I believe that we do still provide a relatively good quality of healthcare to Canadians. I would say that if you want to learn lessons from the Canadian system, as I said before, be skeptical and look carefully at how our system is not working before you assume that it's going to solve the problems that you have. As far as I can determine, and having read most of the so-called important works in this area, as far as I can determine, the problems that you have in America are not going to be solved by adopting the Canadian system or any variant of it that promises universal access to an unlimited quality of health care financed in some collective way.
As Milton said, do we want the people that bring us public education and the post office to be bringing us our health care? And I think that was a very apt comment. I have a small presentation to make to each of our speakers. Normally, we would give them the famous Adam Smith tie, but as both Milton and Mike Walker have enough ties to open an Adam Smith tie shop, we have something else for them. So on behalf of Pacific Research Institute, I would like to thank all of you for coming. And Milton and Mike, would you like to come up, and I will thank you with a small token of our esteem. This is for a Chinese meal for you and Rose. And Mike has been on a diet over the last few months and has lost a lot of weight, but he has given up drinking things with caffeine like tea and coffee, but he's been able to continue to drink liquor, so we have this.
Thank you.
So this meeting is now terminated. I'd like to thank each and every one of you for attending. Thank you.
Very appropriate.
KGO TV wants to do a quick interview with you right now. Is that all right?
I just had an interview with somebody.